on this second webinar of the series about the current pandemic which is going on. We are happy that the first webinar was attended in a very large number. Today we have got two stalwart speakers with us. The first speaker and the first speaker is Dr. Professor K.Ganapathy. Sir is a neurosurgeon from Apollo Hospital, Chennai, and he is the director of Apollo Telemedicine Networking Foundation, as well as director of Apollo Telehealth Services, and also the past president of Telemedicine Society of India. And I must say, he is one of the very few pivotal or instrumental person in getting the telemedicine guidelines that is being shaped in India as of now currently. So today, I think we'll all be having the elaborate knowledge about how to use telemedicine for family physicians. So first we have talk by Dr. Ganapathy and followed by your talk by Dr. Vinod Shah. Our another speaker for today is Dr. Vinod Shah, a senior practicing family physician from Surat. Sir, he is the past president of FFPAI, as everybody knows, and he is currently the director of the Hospital Board of India, IMA headquarters. And he has also had various positions in past. So without much ado, I welcome you all once again on behalf of Team FFPAI, and I will request Dr. Professor K.Ganapathy to start this talk. Dr. Ganapathy, sir, please.
Good morning, everybody. At the outset, I wish to thank Dr. Pragnesh for giving me this opportunity to share with you some of our experience in the last 2 decades in the field of telehealth. I'm dividing my talk into 3 parts. The first would be just a quick introduction to telehealth. Personally, I prefer the word telehealth to telemedicine, particularly where family physicians are concerned. I think you play a very important role, not just in making a diagnosis and treating a patient, but in ensuring that you promote wellness and you ensure that people stay healthy. The second part of my talk will be to demystify, as it were, the current telemedicine practice guidelines notified by the Government of India on March 25th. And the final part of my talk will be on how specifically telehealth deployment is absolutely mandatory in the management of COVID-19. Now, what, ladies and gentlemen, is telemedicine? Telemedicine is a broad term which we give, which encompasses everything completely. Oh, sorry. Okay. Now, which is the ability to, you are able to make a diagnosis by taking the history, clinically examining a patient, relevant, necessary clinical examination done virtually. The entire process of telemedicine includes hardware, software, connectivity, acquisition of images, storage of images, retrieval of images, display of images, and so on. Obviously, there is a healthcare provider at one end and a beneficiary at the other end. Now, you need to be orientation. You need to undergo at least a familiarization, sensitization program, training, customization. Ultimately, a solution is not a solution unless it is available to everyone, anywhere, preferably 24/7. Therefore, it has to be customized. It must be cost effective. In 2020, it is particularly essential that whatever we do is compliant with regulations. It has to be revenue generating and self-sustaining. Philanthropy at the best can start a telemedicine unit, but to ensure that it continues, we have to generate revenue. And of course, it must be future ready. Now, let's look at the different formats in which telemedicine can be practiced. It is what I call synchronous and asynchronous. Synchronous is real-time teleconsultation where the patient is at the other end. However, a considerable amount of telemedicine can be done in what we call a store and forward mode. The history can be sent as a text, physical examination findings can be sent, laboratory investigations can be sent, and so on and so forth. Low bandwidth is enough for many of the earlier components, but if you want to do an invasive procedure remotely, which incidentally is not permitted by the Government of India, we will discuss this later. Video conferencing, of course, will require a much higher bandwidth. Now, I'm quickly going to give you a few examples. Family practice, in my opinion, is the most difficult specialty. It is very easy to be a neurosurgeon like me. It is extremely easy to be a pediatric cardiac surgeon because there you learn more and more about less and less. Whereas it is you, the people, who act is the open the gate literally, and you need to decide whether this patient has to go to a chest physician, a pulmonologist, or whether you can manage the problem yourself. Dermatology is one of the simplest in teleconsultation. We have personally done about 9,000 teleconsultations in the last 20 years. I have a team of about 4 to 5 dermatologists, and they assure me that in 98% of the cases or 99% of the cases, they are able to make a diagnosis with, of course, a proper history. So dermatology, all that is required is an excellent camera and a very good history. History is absolutely vital. Now, this composite slide, you can see the top 2 photographs again show skin conditions. Though I have an MBBS degree, I honestly would not be able to differentiate a mosquito bite from Ehlers-Danlos syndrome, which I studied when I appeared for my examination. For a dermatologist, it requires 2 minutes with the proper history to make a diagnosis. On the lower left-hand side, you can see a patient whom I evaluated in Bangladesh, kyphoscoliosis, pes excavatum, and so on. Obviously, I'm not competent to handle this case. So what did I do? I managed to get 3 experts. You know how difficult it would be to get 3 experts who are particularly doing this. And we were able simultaneously to talk to the family and to tell the patient what needs to be done. Personally, I think it is malpractice. I think it's a crime if a small baby like the one whom you see on the top is made to travel 2,000 miles in order to see the pediatric cardiac surgeon, for the pediatric cardiac surgeon just to look at the scar for an open heart surgery, which he had done several months ago. All this can be done remotely. Today, we have digital stethoscopes, we have echocardiograms. Talking about echocardiograms, when I was preparing for this talk, I myself was surprised that as early as 2001, when the world was not aware of tele-echocardiography, we had already started this. I had a wonderful pediatric cardiologist, Prem Shekhar, who unfortunately left us after some time. And you can see from the village of Aragonda, a trained technician transmitted a pediatric echocardiogram. I'm talking of 2001. Dr. Prem Shekhar had done more than 150 pediatric echocardiograms, and which he was able to evaluate from Madras. So this is the power of telemedicine. There's almost nothing you cannot do with telemedicine. Again, ladies and gentlemen, we run the world's largest tele-emergency center at 15,000 feet height in the Himalayas. Here is an example of a patient who developed a myocardial infarction. We picked up a myocardial infarction as it was evolving. The first ECG was normal, but my doctors are wonderful. They realized that the patient was not looking well. The BP was not actually going up. It is actually coming down. So they insisted that the ECG be repeated after 45 minutes, picked up an ST elevation, and initiated thrombolysis from a distance of 2,500 miles. We told the nurse there to start thrombolysis. Today, we have done 13 cases of myocardial infarction, which were picked up remotely and treated them. Another example of a supraventricular tachycardia, a pulse rate of 240 per minute in the Himalayas, temperature minus 25 degrees centigrade. The telemedicine unit is totally cut off. Nearest secondary hospital, 180 kilometers away, and there's no way you could reach because all the roads are blocked. It so happened that the nurse on duty was on leave. We had not even a nurse, we had a sort of attender who was familiar with just running a telemedicine unit. And again, the wonderful ER doctors I have, they said, don't worry, we will handhold you. And just through an internet and webcam, you can see the pictures on the left. Our emergency ward is one of the best in the world. We have a mannequin, and the doctor there told a person who could not even spell the word fibrillator, had never seen a fibrillator in her life, handheld her, telementoring, told her what to do, what not to do, and she did the first defibrillation in her life, handheld by a doctor from Madras. Patient totally recovered. Today, we have 11 cases of defibrillation we have done over the last 3.5 years. So this is the power of telemedicine. 2 days ago, I had given a talk to more than 3,500 obstetricians and gynecologists. Since obstetrics and gynecology is a significant component of family practice, I'm including this slide here. This is a slide borrowed from the directives of the American College of Gynecologists, and the ACOG very strongly advocates telehealth. You can see here postpartum visits, lactation support, fetal heart monitoring. Today, a high-risk pregnancy, through the internet, we are able to diagnose, we are able to pick up fetal heart sounds, fetal Doppler, and so on. All this is available in India, though it is restricted, of course, at the moment to the bigger centers. Our own experience, we have now reached 10 million teleconsultations in the last 2 decades, the majority of which through government public-private partnerships, states of Andhra Pradesh, Jharkhand, Chhattisgarh, Himachal Pradesh, and so on. About 1,200 obstetrics and gynecology teleconsults have been given. We have picked up anemia in pregnancy remotely. Imagine what it does when you are able to diagnose 7 grams of hemoglobin and you are able to institute the treatment and ensure that the hemoglobin level becomes totally normal. I am told by my gynecologist that several complications like the ones you see mentioned on the slide have been avoided. And of course, pre-existing diabetes, gestational diabetes, complicated diabetes, every one of these have been thoroughly controlled remotely. Our family physician asks for an endocrinologist or a diabetologist's opinion. Now, coming to the pandemic, contrary to general perception, ladies and gentlemen, it is an erroneous misconception that pandemics occurred for the first time. As early as 1348, in fact, the very word quarantine is an Italian word saying 40 days. That was when isolation was practiced. And again, the Spanish influenza, isolation was practiced. In 2020, we are back in the same situation. Now, why have the entire world has recognized telemedicine? The growth of remote healthcare in the last 4 months has been more than it has been in the last century. There are several reasons. One of the reasons is the healthcare physician himself, healthcare provider. We are all aware that in Italy, in the United Kingdom, and the United States, and it is so sad that one of my own classmates passed away a few days ago after 40 years of work in the NHS dedicated service. He passed away after being on a ventilator. Now, this can happen to anybody at any time. Physician, heal thyself. This is one unique situation where the treatment is, what are we advocating in the treatment? We are advocating that people suspected of even having a coronavirus-like illness refrain from attending a hospital physically. And therefore, it is particularly important that remote healthcare be practiced today. All over the World Health Organization, the CDC, China, Hong Kong, Australia, United Arab Emirates, UK, US, you name it, every single government has set up our telemedicine. The government of India has been phenomenal. They have realized the importance of telemedicine, and on March 25th, they formally announced the rules regarding this. Trump has allocated $500 million from his $3 billion initial allotment to tackle the pandemic exclusively for teleconsultation. Every single insurance company in the United States have now recognized teleconsultation for purposes of reimbursement. I used to show this slide for several years. Several years ago, I started showing this slide. Are we ready for a hospital which has no patients? I was talking theory at that time. I said that in my lifetime, we are going to come across a shift, a paradigm shift. Healthcare will shift from the hospital to the clinic. Healthcare will shift from the clinic to the patient's home. A doctor in your pocket, a hospital in your pocket, this is certainly doable. But never in my wildest dreams do I thought that it will come so suddenly and with such an impact all over the world. Over the last 4 weeks, all of us who have been involved in telemedicine, we are literally working overtime. There are at least 150 documented evidences like this. Every single state today, there are private hospitals, there are individuals. The Telemedicine Society of India is working overtime. All the chapters are encouraging this. And I'm very happy to state that this has now become a reality. It is not just a picture you see on your screen. Actually, free teleconsultations are being provided round the clock. And this is done following triage documents notified by the Government of India and changed every day. We still are a little far to achieve this, but it's certainly doable. Today, we can do a detailed clinical evaluation of a suspected coronavirus patient. Thermal sensors are extremely common. All of you are familiar with infrared guns, which will take the temperature for thousands of people. Bluetooth-enabled thermometers are available. This can be transmitted to your own laptop or your desktop, whatever it is. Today, the patient himself can be taught to shine a torch inside his throat, on inside his ear, inside his nose, etc. And you can look at the interior, find out whether there is a throat congestion, and so on. Digital stethoscopes are freely available in the market. Gone are the days when you have to put a stethoscope, the symbol of medical practice, onto your ear. Today, we have Bluetooth-enabled stethoscopes, like the one you see on the left. Not only records the Rals and Rankai, but even gives you a semi-automated diagnosis like an ECG and even tells you what it is. Pulse oximeter, oxygenation is critical in the management of coronavirus, and this can be remotely evaluated. 12-lead ECGs, pocket ultrasounds. Of course, there are a lot of regulatory issues, but eventually all this will be sorted out. So having introduced to you the phenomenal applications of telemedicine, let me go to the second part of my talk. Let me demystify some of the concerns which the medical profession today has regarding telemedicine practice guidelines. Now, I would like to start off by saying, having done a reasonable study of similar legal issues in many, many countries of the world, I've gone through the United States, Europe, United Kingdom, Abu Dhabi, and several other countries. I can tell you with all the authority at my command that I have never, ever seen a notification more doctor-friendly than the Ministry of Health guidelines. Ladies and gentlemen, at this point of time, India is acting under the Epidemic Diseases Act 1897 and the Disaster Management Act 2005. Both these are operational. And this unequivocally states, I'm going to repeat, protection to persons acting under the Act. No suit or any other legal proceeding shall lie against any person for anything done or in good faith intended to be done under this Act. So long as there is no mala fide intent, so long as there is no deliberate intent, which no medical doctor will even think of. Ladies and gentlemen, it doesn't matter if you have made a genuine error of judgment. It doesn't matter if there is a procedural lapse. What we are interested in, what the government is interested in, is the good faith and the patient's interest. Patient's interest, patient interest. This is all that is going to be considered. So please forget about what it is. Do whatever you think is right for your conscience. Now, again, to me, there were two red letter days. To me, March 24, 2000 was a red letter day because it was on that day that Bill Clinton inaugurated the world's first VSAT-enabled village hospital in Araganda in Andhra Pradesh. The ISRO were on the lookout to use satellite technology, space technology for societal applications. And it was a wonderful relationship which the Apollo hospitals had with ISRO, and this was how it all started. Unfortunately, it never grew the way we wanted it to grow. Exactly 20 years and 24 hours later, the Board of Governors, which has superseded the Medical Council of India, formally notified an amendment to the Indian Medical Council Act. Rule 3.8.1 says that consultation through telemedicine by the RMP shall be permissible in accordance with the guidelines. Now, and I think this is a really, of course, the Telemedicine Society of India did play a fairly major role. For the last 3 years, we have been entreating Niti Aayog, the Ministry of IT, Ministry of Law, Ministry of HS, Ministry of Health, and thanks to the coronavirus, all this has taken place in a jiffy. Different types of consultations are envisaged in the practice guidelines. The first is, of course, the routine patient contacting a doctor through the telephone, through a Skype, through a WhatsApp, whatever it is. When a patient initiates the request for the teleconsultation, the consent is implied. Just like a face-to-face consultation, when a patient comes to my office for a consultation, I do not get a specific consent form. It's an implied consent. The implied consent includes taking a chest X-ray, an ECG, for drawing peripheral venous blood for blood tests, and so on and so forth. The same thing in a teleconsultation. However, in case you are giving a consultation as a second opinion to another doctor who is talking on behalf of the patient or who wants a second opinion, it is necessary that you get a consent, a written consent, which is recorded electronically from the patient permitting this. Similarly, a caregiver. There are so many situations, particularly neurological cases, post-head injury, post-stroke, post-brain tumor, hemorrhage in the brain, etc., where the patient is physically not in a condition to be brought in front of a camera. The camera cannot go to the front of the patient. So the caregiver, the law now authorizes you to discuss with the caregiver and to give an opinion. Not only health education, counseling, but even medication can be given through the caregiver. Similarly, an ASHA, particularly in the pandemic domain, a health assistant, a health worker is entitled to seek your opinion. Until 5 years ago, for the first 15 years, in all the lectures I gave, I used to start off by saying telemedicine by definition excludes emergency. Now, ladies and gentlemen, I'm eating my words thanks to my own colleagues. 5 years ago, we started the emergency medical service for telemedicine. Today, of course, the government has recognized it. Today, it is permissible to give a teleconsultation even for an emergency. However, to prevent abuse of this, there are many don'ts, and for lack of time, I'm not going into the details. If anybody is interested, I will be more than happy to discuss this in detail. Now, the government very clearly differentiates between a first consultation and a follow-up consultation. They have unambiguously emphasized that the first consultation between a doctor and a patient need not be an in-person consultation. Obviously, with an acute shortage of specialists and super specialists in the country, the lopsided distribution between urban and rural areas, is impossible to expect a patient to travel 200, 300, 500 kilometers. Therefore, the first consultation can be a virtual consultation. Of course, patient identification, doctor identification is necessary. The doctor must display his registration number and the medical council from which he got this registration and so on. Now, again and again, I want to emphasize that last night, in fact, I got very upset about it retrospectively. I should not have got so upset. A very senior person from the country sent me a mail and said, I immediately want to reply, list out conditions where telemedicine should not be done, list out conditions where telemedicine will save lives. So I was very angry with that and I responded immediately. I said, it's a sad day for the medical profession if we are asked to give a list of things which we should do and a list of things which we should not do. I reiterated, I said, it is clinical judgment, clinical judgment, clinical judgment. This is not a typographical error. The doctor at one end, the patient at the other end, they should be given the freedom to decide based on the context. Everything is contextual. What is totally inappropriate for an MBBS doctor in a tier 2 town is absolutely normal for a telemedicine specialist like me, a super specialist working in a quaternary care hospital in a metro. I can do teleendoscopy. I can do teleophthalmoscopy. I can look at the fundus. But I don't expect a doctor working in a town to be able to have all these resources. Therefore, you cannot pass general discretion. It is clinical, clinical, clinical all the way. Just because you have technology does not mean you can misuse or abuse this technology. I'm quickly going to give you a few examples to indicate to you why clinical judgment is important to execute the telemedicine practice guidelines. I belong to the BC era. I used to say before computers and before Christ. I was the last neurosurgeon in this country who was trained even before the CT scan came. Unfortunately, ladies and gentlemen, now I use the word BC as before Corona and AC as after Corona, because so far as healthcare is concerned, believe me, it is the BC and AC era. Now, as one belonging to the BC era, I refuse to give an opinion. I refuse to give any prescription without having seen the patient. So I was pleasantly surprised several years ago when the relatives, I insisted on seeing the patient. They said, sir, can we show you the patient through mobile phone? I said, fine. through an ordinary entry level, not even a smartphone. You can see the relatives at the home did this, and this is all that I needed. I was able to do a detailed neurological examination. Now, here is another example. This 12-year-old boy from Dubai was referred to me for a teleconsultation with a possible history of seizures. As family practitioners, you all know that 99% of people who come to you for convulsions do not have a neurological deficit. 90% of them, the CT scan will be normal. 90% of them, the EEG will be normal. Diagnosis of a seizure disorder is from the history, and only history. You require an eyewitness. So this is what I mean by saying using clinical judgment. So I said, I will not brand somebody as having a seizure disorder and put him on anticonvulsants for a long time. Nothing is going to happen if he gets another convulsion again. So have a mobile phone ready with you. And the next time he gets a convulsion, record it and send it to me. Now you can see here in this record, a good MBBS student should be able to diagnose a classical demonstration of an absent seizure. You can see saliva drooling from the mouth. It is not a tonic-clonic generalized grand mal epilepsy, but a classical temporal lobe seizure. Now, this was sent to me a few days later. So this is what I mean by clinical judgment. And of course, I gave the prescription. Now, here again is a patient whom I just saw 3 days ago in the lockdown period. Now, this again, you can see here, I'm showing a video. Now, this is a young lady. Okay, fine. Now, this was a lady whom I had treated with CyberKnife stereotactic radiosurgery for a trigeminal schwannoma. Now, this is what I mean by a teleconsultation. She now sought my urgent teleconsultation because she had pain. The pain was not clinically typical of a trigeminal neuralgia, which is what I would expected because the tumor is pressing on the trigeminal nerve. So that is why I was very unhappy. I said I must do a detailed clinical exam. And you can see I got exactly what I wanted. And look at what I have done. I signed, on my letterhead, I write a prescription. I write the diagnosis. Diagnosis, right-sided trigeminal schwannoma, CyberKnife irradiation, October 2019. My working diagnosis at the moment is right hemifacial pain because it did not look like trigeminal neuralgia. Clinical evaluation, no focal neurological deficit, bracket, fundus not examined. But based on my 45 years experience, I was reasonably sure that the fundus was not going to show any abnormality because there's absolutely no symptoms or signs suggestive of ICT. I prescribe a generic name, carbamazepine, and I write at the bottom, telephonic review after 10 days to call such and such a number, my signature, name, my registration number, etc. And on the top, permission obtained from Mrs. So-and-so to record video of teleconsultation and use it without revealing identity. On the left-hand top is a banner with my name, qualifications, registration number, and my photograph. This should be on display on the screen every time I give a teleconsultation for every patient throughout the duration so that the patient knows my credentials and the registration number, etc. So this is not at all difficult. It takes a couple of minutes to start with, and after that, it's very simple. Another teleconsultation I again gave 2 days ago. Now here you can see this was again in Himachal Pradesh. 75-year-old diabetic hypertensive myocardial infarction had an acute subdural hematoma, operated, post-op CT ready. Now this is where judgment and wisdom counts. The repeat CT still shows a residual collection. A young knife-friendly doctor would probably have advised repeat surgery. But taking the overall picture into account, I advise the family that in my personal opinion, the treatment can continue because the patient is not deteriorating, continues to be stable. All the CT pictures are here, and on the left is an extract from the hospital record. Everything must be documented. Nobody can question my decision. Maybe some other doctor would make a different opinion, but this is not an error of judgment. Medicine is not black or white. It is various shades of gray. Now, coming back to the rules, the guidelines have clarified that the patient will be primarily responsible for accuracy of the information. Again, the caregiver, in this case, the patient was not in a position to communicate with me. The previous case of head injury, it was a wife. I satisfied myself that this lady was indeed his wife and that she was interested in the patient. And therefore, whatever information she gave me, I took it as if I had got the information from the patient. I've already mentioned to you the importance of documentation, compliance, adherence, etc. Now, again, the guidelines perfectly allow you to charge your fees. You have every right to charge your fees. You can charge appropriate fees for a teleconsultation. A receipt or invoice can be sent electronically, and this is valid for reimbursement, insurance company, in a court of law, etc., etc. Now, what fees you charge? A general guideline is that you charge whatever you normally charge, neither increase nor reduce the cost. Now, it is mandatory for doctors to prepare, maintain, and preserve the patient's records. One of the reasons why the guidelines mention this is, again, the government is very keen that every one of us, it's just a question of time. I'm sure in 2-3 years, every doctor in this country will have an electronic medical record, which will be available, what is called an MPHR, Mobile Personal Health Record. EMR is slightly different from EHR. I'm not going into the details, but whatever it is, eventually, and organizations like yours, the family, the physician associations of India, etc., family practice, you can make a tremendous difference. And I know there are groups of people who are extremely IT savvy, who are interested in this. And this is a plea to all of you. Please start using electronic medical records. Prescriptions, this is a question which I'm often asked. Again, a very, very forward step. No doubt pandemic associated is the fact that the government has said you do not require all the time a formal digital signature. A digital signature is actually an encrypted signature, class 1, class 2, class 3, which can be given only by an authorized company. However, under the telemedicine practice guidelines, you give a prescription as you normally do, then with your signature, with your registration number, etc. As I showed you in the previous slide, just either scan it or take a photograph. Today, every mobile phone has a camera. Take a photograph and send it. The present law clearly states that the pharmacist will have to dispense a drug even without a written paper, provided the registration number and the council from which the number was given is there, and the diagnosis is there, and the detailed prescription is there. So this can be done. Now, again, there are e-pharmacies. There are a lot of pharmacies where doctors sometimes communicate directly. The guidelines unambiguously state that you cannot send a prescription directly to the pharmacy of your choice unless you have the written consent. When I say written, I'm all talking digital. Unless you have a consent to the patient agreeing that you can send this to a particular pharmacy. So every single guideline is mentioned. Of course, there's a long, long way to go. Please remember, all this was done in a frantic hurry. During the last 2 weeks, FAQs, we have already commenced a program. We have got the feedback from more than 1,200 doctors. A group is preparing all the FAQs. And within a week or so, we are going to approach the government once again and tell them that 2.0, version 2.0 has to come. Please understand that this is a dynamic document, not a static document. Many of you will find fault with several things, but Rome was not built in a day. Give us some time, and I'm sure in another couple of months, we will be able to do what should be done correctly. Templates have been prescribed, and again, list O, over the counter, list A, list B. Of course, the guidelines very clearly state that psychotropic drugs, narcotics, drugs where one can become addicted to, cannot be prescribed through a telemedicine consultation. Again, a video consultation is absolutely necessary to prescribe certain drugs. Some exceptions are given in the pandemic till such time as the pandemic is denotified. All these details are available in the Ministry of Health website homepage. Please go to MOH. It's so simple that everything is given. This is a copy of the prescription. But again, the government gives you the freedom. It recommends this, but it is not absolutely mandatory so long as all the information required for is available. Again, this particular notification has excluded, deliberately excluded any discussion on specifications for hardware, software, infrastructure building, maintenance. Nothing is mentioned about backup copies, electronic backup copies, who is responsible if there is a virus. I'm not talking about coronavirus, I'm talking about computer virus. What happens if the file gets corrupted, etc., etc. There are so many details to be gone into regarding digital technology. This will probably be issued in the next 2.0. One thing which the government has made very clear is that as things stand today, it is illegal to conduct any telesurgical or tele-invasive procedure remotely. A couple of months ago, you must have read in Gujarat, an invasive cardiologist
Just hold for a second. Might be some technical issue. Hold for a second, please. We are getting a lot of questions. Do wait. We'll answer. We'll get sir's answer most of the questions. For a second. Please bear with us for a second. We'll have some technical snack. So please wait for us. We are looking into it. Just wait for a minute. So this is a very interesting discussion and very important guideline shared by Dr. Ganapathy, that telemedicine is the future and the new thing that has come up. So now the task is to have more and more family physicians and more physicians across India to get trained in telemedicine. So with the help of Telemedicine Society of India, that is TSI, we are working towards getting more and more telemedicine, because there is a lot of say anxiety among doctors about using telemedicine, because this, as sir has likely said, the time will be now be marked as after COVID and before COVID. So after COVID, the way doctors practices, especially the family physicians, will be changing in a very dramatic way. And I think the time has come that every family physician should embrace the technology, because as we all know, the learning has nothing to do with the age, and age is no bar for learning. So we must work on that, and telemedicine is a tool that can take us to the places. Especially in this COVID era, when we family physicians are wary of seeing patients in person who are suffering from fever, cough, cold, and maybe examining his or her throat and having issues that we may contact corona, and that there are all the likely chances that we may get contacted, we may contract. So in that era of current times of corona, I think telemedicine can be a very useful tool for family physician, and that was the sole purpose of organizing this presentation today. So there are a couple of questions that what will be happening at the platform, the technical platform that we use, what about the security and safety of that? But I think as said by a cyber technology expert last evening, that any software or any platform that you use may have some security flaws to an extent. So let's not worry about it and start embracing technology at the earliest, because this is the need of the time. The first and foremost, this sort of a teleconsultation helps us to save the data on both the sides. The data is saved on the user side as well as the doctor side. So records are automatically kept. We can keep the video and audio records also, so that becomes easy. And we know we have family physician practicing in years. Looking at the face of the patient, or looking at the patient, we can make a good, say I can say 80% of diagnosis by looking at the face of the patient. So when we see the patient, maybe via video or something, I think that is of tremendous use. So that is quite helpful. So I think we'll take questions later when Dr. Ganapathy joins. I think let's move on to our next speaker, Dr. Vinod Shah. Dr. Vinod Shah, as I already introduced him, Dr. Vinod Shah is a leading family physician and the past president of Federation of Family Physicians of India. And sir is right now the director of Hospital Board of India. I am a headquarter. See, before telemedicine has come, telephonic consultation was the big norm, and everybody was working it. And any hour of the day, we got a call that, sir, this is happening. ये problem है, ये वो problem है, इसके लिए कुछ दवाई prescribe करो. And we gladly oblige them by responding via SMS or WhatsApp. But is this the right way to do? Yes or no? That Dr. Vinod Shah is going to tell us. And all the medical councils, as the Gujarat Medical Council has come up with some of the guidelines for telephonic consultation. So let's hear Dr. Vinod Shah. Dr. Vinod Shah, sir, please go ahead.
Good morning, friends. President FFPAI, Dr. Bajpai, Honorary Secretary, Dr. Shah, coordinator of this excellent webinar, Dr. Pragnesh, and my dear friends. At the outset, I am very thankful to FFPAI for inviting me for today's telephonic talk and guidance by family physician. Friends, we are listening the stalwart neurophysician and pioneer of telemedicine, Dr. Ganapathy. Meanwhile, I am just giving my views on telephonic consultation guidelines. The rationale of telemedicine, it's from my telemedicine man. What's the purpose of telemedicine? It outreach of the quality health services to all parts of the country, faster, cheaper, and more communicative medium for medical education, consultation, follow-ups, record copying, and sharing of required information. Better healthcare by consultation with the experts of the various fields. Is there any demarcation between telemedicine and non-telemedicine? But it's not clear. Telemedicine, secure video conferencing or store and forward technologies to provide or support healthcare delivery. In non-telemedicine, telephone calls, WhatsApps, Facebook, Twitter, email, image is transmitted via fax and text without visualization of the patient. Can patient consult the doctors? And can doctors prescribe the medicine on telephone, video calls, SMS, or WhatsApps? Friends, we know most of the world is grappling with the COVID-19 pandemic, and in a country like India, which has a very low doctor to patient ratio, 1600:1, has to be extra careful in deploying its healthcare professionals in the most efficient manner. Dr. Ganapathy already said the government of India very appropriately in this situation has come up with guidelines for practicing telemedicine. 3 weeks back, on 25th March 2020, the Board of Governors has framed the telemedicine practice guidelines, which are added as Appendix 5 of the Indian Medical Council Professional Conduct, Telemedicine Practice Guideline, and Etiquette and Ethics Regulation. On what it said, on 25th March 2020, Telemedicine Practice Guidelines notified that physical assessment and physical consultation is not mandatory. Till now, it was compulsory, and telemedicine is now legal. Doctors can consult, manage, prescribe on phone, SMS, and WhatsApps. Who are the stakeholders? Patient, doctors, paramedics, pharma industry, insurance sector, policy makers, law implementing agencies, and law agencies. What are the elements of telephonic consultation? We have just heard prescribing medicine. First and foremost is consent. Either it is implied or explicit. If patient initiates the telephonic consultation, it is implied consent. When RMP, healthcare worker, caregiver initiates daily consultation, then it is explicit. And we need to ask for the consent. What are the type of consultation? It is the first visit and then follow. Patient evaluation and management. RMP may provide the health education literature, detailed counseling, manage the condition, and prescribe the medicine. Medicine may be prescribed only when RMP is satisfied with the medical condition is based on finding. Prescribing medicines without an appropriate diagnosis or provisional diagnosis would amount to professional misconduct. Telephonic consultation, a family physician perspective, day-to-day life. From last many years, we came across a number of patients and any odd time on us. Telephonic consultation is a day-to-day situation that every doctor faces in one way or another. However, most doctors remain confused on how to handle this situation. Telephone consultation increased in this COVID-19 pandemic time. What are the problems related to telephone consultation? Calls can come anytime, early morning, late night, midnight, whenever we are either taking our lunch, dinner, anywhere, and the doctors may not be even prepared or free to take food. Telephonic consultations are time consuming, as some patients take lots of time to explain and discuss their problem. While in our routine OPD, we get the call from our patient, our OPD gets disturbed as communication with the next patient in the clinic really suffers. It's often difficult to recollect patient's history on the spot. And friends, most important, financially, it is not the rewarding. And most patients don't want to pay for kind of consultation as they are not habituated. Serious mistake can be made in patients hearing the name of the prescribed medications, and this can put patients on risk too. So without knowledge and consent of the doctors, many patients record calls. This is also against the law. So practical aspect and problem areas. It is a necessary evil. Whether we wish or not, we have to talk with our patient. Patient prefers to call. His mobile is very handy and talk to doctor rather than visiting them for minor ailments for giving them updated reports hand to hand as they can use WhatsApp easily. Yes, sir. You just open your WhatsApp. I have sent the reports. I have sent our X-ray, MRI reporting. We have to read and then again we have to refund him. It saves patient time and money simultaneously, even friends. It consuming of doctor's time, loss and financial loss too. Reaching the doctor over telephone is quite helpful when the patient is traveling or on holidays or when the doctor's clinic is closed. Mobile phones have created havoc as they are often being misused by the patient as an inquiry services. And VIP patients exploit the doctors very often. Now we just go through what are the elements of the telephonic consultation. First is the type of prescription. Prescription to be according to ethics regulation. Dr. Ganapathy said signed prescription to be provided is always must mention of a registration number and photo or scanned copy of prescription to be signed digitally in case of e-prescription. The family physicians are required to maintain documentation of consultation. RMP may charge appropriate fee for telemedicine consultation and also for the invoice for the fee chain. What point or what precaution we have to look for? Prescribing medicine without an appropriate diagnosis or provisional diagnosis will amount to a professional misconduct. What Dr. Ganapathy said, medicine listed in Schedule X of drugs and cosmetic and rules or any narcotic and
internet connection is unstable.
The narcotic drug, the psychotropic substance 1985 not to be prescribed. We are not permitted to solicit patients for telemedicine to any advertisement or inducement. Based on artificial intelligence, machine learning are not able to counsel the patients or prescribe any medicines to a patient. Guidance don't cover consultation involving patients or doctor outside India. So what are the legal aspects? For patient, it's privilege to expertise, availability and reimbursement of the amount paid to fees. For doctors, credential for telemedicine treatment, access to patient data, standard protocol, remuneration. Ethical aspect when we look for patient privacy and confidentiality must be maintained and the right to avail required treatment and expertise informed from the consent. For doctors, responsibility of the correct treatment, data use of treatment and research must be maintained. Privacy, confidentiality maintained and commitment to meet the patient directly in local condition adoption. Friends, recently on 16th of April, we received guidelines from the Indian Medical Association. What Indian Medical Association advisory says, IMA recognizes the use of online facilities on telephonic consultation by the member in the professional services to the patient only on 2 occasions. In triaging patient, we have to select if there is a heart attack patient, myocardial infection, first give and prioritize them. So in triaging the patient and identifying the patient who need the treatment and go over to hospital. Advertising regular patient like diabetes mellitus, hypertension, and review the continuous treatment. Only last 2 sides. As of today, there is lack of clarity on medical legal implications. Procedure prescribed by statutory bodies don't necessarily absolve the doctors from his liability. So what is the take-home message for telephonic consultation by our FFPAI members? Legal protection to doctors practicing telemedicine during the COVID-19 pandemic under Telemedicine Practice Guideline 2020. Section 4 very clearly says the Epidemic Disease Act 1896 No suit or other legal proceedings shall lie against any person or anything done intended to be done. Under this, it clearly says the proper basic precaution of infant these can benefits avail, assess the patients adequately, inform the patients about limitation of telephonic consultation, and detailed documentation of medical records if maintained. We can definitely provide best telephonic consultation to our patients. Thank you very much.
But why didn't you tell me? Please talk in English. Why didn't you call me and tell me? He says he called 3 times. Neither vibrator mode la poturundhudu idu pottanu. I know, but I can't. When I am talking, I can't be looking at messages, isn't it? Sorry, all right. Now, what do I do? If you want to answer questions, I'll answer. No, man, no point in that. I should have told you. See, you're not that to the phone. Vibrator mode. Here in the vibrator mode. This thing in the park.
Thank you, Dr. Vinod Bhai. Thank you. And extremely sorry for the technical snag that has happened, and we have missed the last part of Dr. Ganapathy's lecture. Sir, would you like to say something on concluding remarks, sir?
Hello.
Ganapathy sir, would you like to say something in concluding remarks, sir? Ganapathy sir? Hello?
Can you hear me?
Yes, Ganapathy sir, I can hear you, sir. Please go ahead.
Okay, I'm very sorry. I didn't know. I went on talking for 1 hour non-stop. I had no idea that you were not listening to me. I wish I'd been. I went on talking non-stop till the very end for 1 hour.
Sir, only last 10 minutes have lost. Otherwise, we could hear everything, sir.
No, up till what time did you hear? Did you hear about the importance of telehealth and coronavirus?
No, exclusions. After exclusion, we didn't see anything, sir. After the slide of exclusions.
That was the most important part. Is it too late now to talk again about it?
No, it is not late. You can go ahead and finish it, sir. Absolutely, it is not late.
Okay, but it's not too late. Please apologize for the audience. I don't know what happened. I will just give me 1 minute.
So please stay with us. We will be starting in this. Sir is starting. सर वो कहते हैं ना बड़े-बड़े देशों में छोटी-छोटी बातें होती रहती है तो सर that's fine sir. We don't want to miss anything from you.
Okay, 1 sec. Family physician. The laptop.
Yes sir.
Just 1 minute. I'm putting it in the laptop.
Vinod bhai, coming back to you soon.
Okay, laptop report. That's your family physician. That's the desktop report. Laptop family physician PPT.
Yes, sir. Please go ahead and share the screen.
Yeah. Just give me 1 minute.
Okay, sir. Okay, sir.
Another control. In the meantime, if I want to ask some questions, I can ask. Okay, let me finish.
Yes, please, sir.
Yes, family physician. This laptop another.
Sir, can you answer questions in between, sir?
Yeah. Or I think it'll be better if I I think it's better if I do it at the very end. Yeah, just give me.
Fine. Vinod bhai, can I ask a question to you? The delegates.
Yeah, I'm just switching on my PowerPoint.
Yes, sir.
It's a big presentation, so it's taking some time. I think there's my internet speed has gone down because once in a way I'm getting internet unstable.
Sir, there was a question related to that. Can we start asking you that?
Yeah, okay. Zoom on. This is not opening. Zoom on.
Vinod bhai, a question for you in meantime.
Yes.
Just a second. Sir, I started. Vinod bhai, there is a common question that how do you control the influx of questions on telephone? Because as you already mentioned, patient can call at any moment of time and just ask questions. How do you control that?
No. The practice guidelines very clearly state the doctor has every right to be available only at a particular time. So you can say, I will be available from 9 a.m. to 10 a.m., Monday, Wednesday, Friday, whatever it is. So it's entirely your prerogative. Nobody can ask you to answer it every time. And if you want to charge for the telephone consultations, you are at liberty to charge. Also, if you want to do it as a free service, you do it as a free service.
Okay.
Okay. Dr. Pragnesh.
Yes.
What I did this time, I have prepared the broadcast group of all my patients. I have collected a number of almost all the patients. I have requested them that whatever time you want my services on telephone, kindly just consult me between these hours, morning 9 to 11 and evening 4 to 8.
Right.
After 10, you never disturb me. I will be highly obliged if you never call me after 10 and before 8. Gradually, they just get adjusted with me.
Okay, that is great. And how do you collect payment on phone?
It is a very tricky question. I have two types of patients. One, they are
paying. How?
Vinod bhai, go ahead.
With the Paytm, I have, and the BMAP, I ask them to kindly you just send the amount. And directly they are also, I have given my bank account also. The most of the patients have directly deposited and credited their amount to my bank account, as well as to application.
Okay, fine. And do you think when we do telephonic consultation, we feel that we miss that touch and feel of the patient? And that is, I think we family physicians learn an art of practice to that only.
So what happened, Dr. Pragnesh, in last 2 months, right now I have 5 to 6 ECG of the patient, 30 to 40 various skin condition patient. They just send the photograph, we have to prescribe. And I request them about the payment, but payment part is still difficult. In 50% of the patient, they directly offer from them side.
Okay, I'm ready.
Okay,
Can
sir.
I continue, please?
Yes, sir. Yes, sir.
Okay, the exclusion slide you had seen, right?
Vinod bhai, hold for Vinod bhai, now let's continue, sir. Let's sir.
Exclusions you had seen.
Yes, sir. Exclusion. Yes.
Okay. First of all, my sincere apologies. I was so engrossed in this. I had no idea you were not seeing. I had completed my talk. So now I'm going back. This is again to prove a point that technology is only an enabler. It's a means to achieve an end and not an end by itself. A fool with a tool is still a fool. And I think this was a classical demonstration how with all the technology in the world, I went on talking, not realizing that there was nobody at the other end. My sincere apologies. I know how absolutely disconcerting it is to come for a talk and then realize that a talk is not there. But believe me, please sympathize with the speaker. For the speaker, it is even worse, not knowing that. See, normally in an auditorium, I can hear snoring. I know that people have fallen asleep. So there's a body language. So I know people want me to shut up. So I stop talking quickly. Here, unfortunately, I have no idea who is at the other end. So my apologies once again. Now, as you can see, the government is very serious because they frequently ask questions. They have put it up immediately. And what I had mentioned in conclusion was that none of these rules, guidelines have been written in stone. Even a 5-bench Supreme Court judgment is being reviewed. Interpretations differ. Test case is required. So please remember that the doctor-patient relationship is critical. No one ever goes to court. No patient is going to file a suit against you or go to the Consumer Protection Forum unless the patient is annoyed, angry with you. It doesn't go to court because of a bad result alone. In 45 years of clinical practice, I have not had a single case against me, not because I'm an outstanding doctor, but perfectly because whatever excuses I made, whatever mistakes I made, I have communicated with the family and the family knew this may happen and were prepared for it. So please remember, at the worst, it can be a procedural lapse. It was Winston Churchill who said during the Second World War, never let a good crisis go to waste. I think we are now talking of the BC era and the AC era, before Corona and after Corona. So now let's go to the final part of my talk, which is the specific deployment of telehealth in the present situation. As of today, more than 2.3 million cases have been proved to be Corona positive. The death rate alone has exceeded more than 160,000. And though India seems to be flattening the curve, please remember, we are no way free from this disease. Now, the coronavirus has in a few months transformed life on this normally peaceful planet. Exponential disruption, not because of the virus biology per se. The virus, remember, is only 130 nanometers with less than 30,000 adenine, guanine, cytosine, thymine, uracil, 30,000 Dalton. That is all. It's such a small strand of RNA. But because of the consequence of massive global pressures to contain the rapid spread, the global economy is going for a toss. And that is why all of us are concerned about this. Now, let's go into the specifics. I had mentioned when I thought I was talking to you that today every ASHA or basic health worker is already empowered, is digitally literate, has a tablet, and using self-evaluation screening forms, such as the one provided on the left, which is being constantly updated by the government, is being customized for specific hotspots and specific for other areas, etc. It is possible today to administer this questionnaire, not to thousands, not to 100,000s, but to millions of people literally. And this tele-screening will clinically identify those requiring laboratory tests. Now, in the event of a clinical suspicion that a test needs to be done, time-specific appointments can be made. Imagine how wonderful it is if a person is told that an appointment is given for a blood test at 10:30, 10:45, 11, 11:15, and so on. Okay, you may have to wait for 30 minutes, but it will be far better than hundreds of people waiting the whole day. Again, results of lab tests can be communicated electronically and symptomatic treatment also initiated. Managing the coronavirus is essentially keeping sick people out of hospitals. Telemedicine is a safety valve for strained healthcare. Virtual visits can decide who needs to be tested for COVID-19. I've already mentioned about the automated screening algorithms. It is critical that COVID-19 suspected patients are not referred to casualties or OP services, but most of them, the management can be done remotely. A single remote clinician, even if he is quarantined, even if he is corona positive, he continues to be physically and mentally in top form. He can screen 100 or 200 patients from his quarantine room. I deliberately put up the slide on the left to show that as early as 2002, there were many of us who believed that remote healthcare is the future. It is very simple to do a detailed clinical examination. Health education regarding the epidemic can also be done through animations, videos in the local language, and this can be delivered to mobile phones. Ladies and gentlemen, I think the time has come that telehealth should be notified as a critical component of India's national strategy to build capacity to combat the coronavirus. The Prime Minister has, in every single time he addressed the nation, he has been repeatedly mentioning telemedicine. The Department of Ayush, Ayurveda, Unani Siddha, and subsequently the Homeopathy Council have all notified telemedicine applications for the so-called alternative medicine. All stakeholders in the ecosystem, whether it be central government, state government, private hospitals, insurance companies, laboratories, and most important, you and I, the individual beneficiary, every one of us play an important role in realizing the potential of telehealth. Resources need to be mobilized to build infrastructure and capacity. It is not easy to set up a telemedicine unit overnight. Neither is it impossible. At the end of the day, it has to be revenue generating to become self-sustaining. Therefore, as private practitioners, we need to negotiate with the state governments, with insurance companies, etc., persuade insurance companies to reimburse teleconsultations. This alone will facilitate direct, easy digital payment by patients. Today, fever, cough, shortness of breath, everything can be evaluated through a video. I don't need sophisticated lung isotope scans. I don't need CT chest. I don't need so many things. All I need to ask the patient to count up to 30. If he's not able to count up to 8 or 10, I can see myself that his respiratory reserve is compromised. All this can be done by any doctor. So it is clinical judgment that is required. A digital stethoscope can transmit lung and heart sounds. It can amplify heart sounds. In fact, semi-automated diagnosis, RALs and Ronchi, gone are the days of basing your diagnosis only on an ejection click on third heart sound, fourth heart sound, etc. Very soon we will have pocket Dopplers. These are already available, and it's just a question of time before a general practitioner, family physician starts using this. Triage chart, as the one you see here, are available in plenty, and these sensitivity and specificity is extremely high. When I was a medical student, there was one All India Institute of Medical Science in this country. In the last 5 years, I think almost 20 AIIMS are coming up and another 15 are on the market. Similarly, Indian Institute of Technology, medical colleges, from 100 medical colleges today, it is 450 medical colleges. Why can't we have a telemedicine center, a full-fledged telemedicine center in every one of the 720 district hospitals, in at least 1,000 to 2,000 secondary, tertiary hospitals? I dream of the day when NABH will ask whether you have a telemedicine unit, not whether you have complied with A, B, and C. Today, a CEO wants to have a cardiac cath lab, he wants to have an intraoperative MRI, and he wants to have a gamma knife. I look forward to the day when equal importance is given to telemedicine units. The Apollo telehealth system alone, just to give you an example, does almost 9,000 to 10,000 teleconsultations every day. So do Arvind Eye Hospital, Shankar Nethralaya put together. There are at least 600 telemedicine units in the country which are fully operational. I think the coronavirus will ensure that the 600, we add at least 2 more zeros. In conclusion, I would just like to once again entreat you, beseech you, request you, literally fall at your feet. Please, please, please join the orientation program which the Medical Council of India have asked the Telemedicine Society of India to start. We have done a pilot project now. Right now, as I'm talking, a session is going on, one in the morning, one in the evening. About 1,500 doctors have attended this so far. We have got tremendous feedback from them. We have reduced the duration from 3 hours to 2.5 hours and so on. Everything is available until 30th of April. It will be done free of cost. This will give you a very good idea on how to practice telemedicine. So I think I'm extremely sorry. I once again apologize for the technological problems, which I did not even realize had happened. And I do hope that some of you have still stayed back. Not all of you have left. I know Sunday morning, there are much more interesting things to do than to listen to a lecture. And one great advantage of a virtual lecture is there is no embarrassment at all. You can be eating, drinking, you can do what you want. And I wouldn't know, the speaker would not know at all whether you are there at the other end or not. So once again, thank you very much for coming, and my sincere apologies for this fox paw on our part.
Thank you, sir. That was a very nice presentation. Obviously, we know hiccups are always there, and even in the routine CMEs, we have seen that at times projects that don't start or laptops get disconnected. So it's a part of life. I think the digital life, you have to learn with it. Now, I will ask questions to both of you one by one. Ganapathy sir, there is a question that whether telemedicine means only video consultation or a telephonic consultation is also considered as a part of telemedicine.
As per the practice guidelines, a telephonic consultation is also an inherent part of telemedicine consultation, includes SMS, includes WhatsApp, includes chat, includes chatbot, and artificial intelligence. They have specifically mentioned that you may use a clinical decision support system to help you with an artificial intelligence guidance, but the communication has to be done by a human being, and you cannot use a chatbot or a robot for the communication part of it.
Okay, so by any mode, when we are not seeing the patient and advising patient by say per se, you can say it is a telemedicine consultation.
Yes.
Okay, and for doing video consultation, what are the options that do we have? Because normally what we use is a WhatsApp video calling and any random website that are available. Any standardized platform you can throw some more light on, which can be used by common doctors?
The technical standards have already been notified by MIT. Those interested, just go to the MIT Ministry of Information Technology website, type in standards, telemedicine guidelines, all that will come. But practically, particularly now in the pandemic situation, I mean, a good video. See, again, as I'm repeating ad nauseum, you need clinical judgment, clinical judgment, clinical judgment. If you're not happy with the image you got. Now, for example, I, as a neurosurgeon, I'm giving a teleconsultation on convulsions, seizures. I'm not too much bothered about the quality of the image which comes to me when I see a patient. But for a dermatologist who has to make a difference between whether this is a drug-induced erythema or a mosquito bite or something, the quality of the image is absolutely critical. So he cannot compromise on that. So to a large extent, whether you use a video with 10 Mbps, 2 Mbps, 256 kbps depends on clinical judgment. An obstetrician gynecologist, where is only history, diabetes, hypertension, asthma, COPD. I mean, the chronic diseases which most family physicians deal with, the video and the image are really not that critical.
Okay, fine. And in the guidelines that you have mentioned, that these are the released by Ministry of Health and Family Welfare, is the guidelines are available, means applicable across India, or every state has to come up with its own set of guidelines?
That's a very good question. There are, see, I understand that as of 2 days ago, at least, these guidelines have not yet physically reached the health secretary of each state. Health, as you know, is a state subject. But yes, under the present pandemic situation, the Ministry of Health expects this to be implemented by every state. Many states, at least about 20 states, I have copies. The State Medical Council has also notified all people who have registered under their medical council that whatever is mentioned in the guidelines can be used. But the final position will be known very soon. But all these are academic. I once again implore every one of you not to get worried because this has not been notified by a state medical council. It has been notified by the Ministry of Health, Government of India in their website, and I think that is enough. The Medical Council of India amendment has also been notified.
What about after Corona? The same guideline will be continued?
Yes, sir. The Board of Governors have informally told us during discussions that this is a permanent, will not be denotified. Some of the clauses which are a little lax during the epidemic may be enforced a little more strictly. But during the epidemic is concerned, they will not enforce even what are in the guidelines very strictly unless a fundamental mistake is made. But the answer to your question, these are permanent. It has nothing to do with the pandemic. The pandemic only accelerated the date of notification. Notification is permanent, lifelong.
Then what about Supreme Court judgment and everything when there is negligence about doctors and
sir, it is extremely unfortunate that the media has totally erroneously reported. We have done detailed studies. The Supreme Court, nobody has said that telemedicine is wrong, is illegal. What the Honorable High Court said, and I totally agree with them, was it is illegal to prescribe anything on a telephone without satisfying yourself of the clinical condition of the patient at that time and without making a working clinical diagnosis. So when I prescribe crocin, paracetamol on a telephone, when somebody comes to me with headache, in the prescription I write tension headache, psychogenic headache, or NYD headache. That is good enough. NYD means not yet diagnosed headache. It means that I take the responsibility that this headache is not due to an aneurysmal bleed in the brain. It is not due to a brain tumor. It is not due to meningitis. Headache can also be due to meningitis. So it is wrong, illegal to prescribe something without making a provisional diagnosis. And in the cases cited, the doctors had prescribed based on having seen the patient 5 days earlier, which is totally wrong. So even if you have treating a patient with diabetes for the last 3 months, clinical judgment implies that you do not repeat metformin 500 milligrams twice a day. You do not repeat it without getting a history, whether in the last 1 week there has been any evidence of hyperglycemia, when was the last blood sugar done, etc., 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 and only then prescribe the drug. You cannot refill a drug. Now, for example, when I prescribe anticonvulsants, which has to be taken for 4 years or 5 years, the court expects me to be smart enough to understand whether the person has got jaundice, whether he's got any renal problems. Could the lady be possibly be pregnant? I have to rule out pregnancy. I cannot go on repeating a prescription just because a person has to be taking drugs for a long time. All this can be done, should be done, must be done remotely. So if you have not done this, of course you are liable for action against you.
Also, most important part of the physical examination we are missing in telemedicine, the art of clinical medicine, totally we forget them.
Yes, sir. Now, again, I beg to disagree with you completely. It depends on the individual case. I passed my MBBS 50 years ago, but still, I'm assuming you don't have to do a physical examination every week or every 2 weeks for a diabetic, hypertensive, person with asthma, person with COPD, etc., etc., etc. Obviously, I do not expect you to diagnose and prescribe. You can even diagnose. I don't expect you to advise hemorrhoidectomy for a patient with suspected piles only through a telemedicine consultation. Now, I am an old-fashioned doctor. I would like to do a rectal examination when I suspect enlargement of the prostate. Obviously, I'm not such an idiot as to prescribe, do it through telemedicine. However, a 30-year-old US returned doctor may be very happy with a superb 4D ultrasound image of the prostate, and he may say, this ultrasound image gives me all the information which I want. I don't need to do a rectal examination, and he will advise the next course of treatment. So please remember that there cannot be a single rule which fits in with everybody. Telemedicine is appropriate for Dr. Ganapathy working in Apollo Hospitals, Chennai, with 4 decades of experience. But the same telemedicine is not appropriate for an MBBS doctor in a tier 2 city where he must do a physical examination. So every case has to be customized. Never ever force telemedicine on anybody. Patient says, no, I want you to touch my hand. Now, for example, pregnancy. I would not expect an obstetrician to do a remote palpation to find out whether there's a fibroid uterus or not. On the other hand, an ultrasound may give enough information. So please remember, it depends on the individual clinical situation, the context in which telemedicine is done. Nobody is advocating telemedicine to replace clinical medicine. I've been again and again and again telling you, sir, I do not treat a laboratory report. I have seen at least 100 people in the last 30 years who CT scans and MRIs show brain tumors done for a head injury. They have no neurological deficit. And because I'm not a businessman, I have just them up for many years without doing anything. Clinical judgment, professional competence, professional wisdom, do things in good faith in the interests of the patient. Nobody can find fault with you.
Thank you. Sir, in between, we have seen one slide that is for triage of COVID patients via telemedicine. That was, I think, a very important slide for family physicians. So I think would love if we can share that slide so we can circulate among our family physicians.
Okay, I'll do that.
And number one, you mentioned about digital stethoscope. But I think digital stethoscope can be used by a paramedical person at one distinct place when the doctor is not there. Am I right, sir?
Absolutely. The whole purpose of a digital... See, we have, in our own practice, we have taught patients, relatives, the patient himself. You don't need a professor of medicine, All India Institute, to put a stethoscope on somebody's chest. You don't require a nurse. You don't require a paramedic. The person himself can put it on the chest, and through a webcam, I can tell you, go infraclavicular, go supraclavicular, go down, go here, etc., etc. No, after all, it's only placing the stethoscope.
So I think, sir, look, after listening to the presentation from both of you, I think we family physicians should have put a cubicle outside the clinic wherein patient can sit and we can do teleconsultation by sitting inside the clinic and seeing the patient without touching the patient, I guess.
If I may just add two things, the family physician will save valuable time in traveling from one place to another place. He will save a lot of money in putting up a big posh clinic with a secretary outside that, this, etc. You will be able to spend more time with the patient, which is what ultimately all of us entered the medical profession, because I love patients. That is why I became a doctor in the first place. A doctor will take more responsibility for managing his own health. He will fill up pro forma. He will take his blood pressure. He will take his blood sugar. He will fill up the history. He will fill up everything. So I will only supplement it with asking a question or two. I will not be spending time in doing things which someone else can do. I will spend quality time with the patient. I will be able to sympathize, empathize. I'll be able to listen to a patient.
And one more important point, sir, that I think you have mentioned in your presentation is that telemedicine consultation can be done with a new patient also.
Can be done with a
new patient whom you have not seen in past.
Yes, absolutely, absolutely. You don't need, it is not restricted to follow up alone. Again, your clinical judgment, whether you can do it through video or not.
That is fine. That is fine. Vinod bhai, a question has come again. Somebody has missed. How do you collect payment in telephonic consultation?
I think it's very simple. I mean, the younger generation are all experts in it. You have a PayPal, credit card, debit card, net banking. I mean, I don't know much about it, but I know that my servant maid now wants her salary to be transferred through Paytm. You know, that is the world we are living in now. So payment is the least difficult part.
And those who have missed, please remember one of the points shared by Dr. Vinod Shah, that Dr. Vinod Shah has got a broadcast list of his patients wherein he shares information with the patients about his availability. So that always helps the doctor in have a quality time. So patient just don't engage at any time. Right, Vinod bhai?
Yes, right.
Okay, sir. So I think would like to conclude here, and we have got a good presence here. So thank you both the speakers for sparing your valuable time, and thank you the hundreds of delegates who are listening to us online. So we'd like to conclude this session here. This is the second in the series. And as Dr. Ganapathy sir has rightly said, we'll make sure that all of this who are attending this session will get a due training from the Telemedicine Society of India in short time. Friends, we will be having a third session on the coming Wednesday at 2:30 p.m. We'll be having two stalwarts with us. One is Dr. Varun Patel, who will be talking about family practice in the post-COVID era, means the post-lockdown, not post-COVID. And we'll have Dr. Vihang Vaya, a leading psychiatrist from Fortis, Mumbai, who will be boosting our morals and will relieve a lot of our anxieties. Thank you. Thank you very much from Team FFPAI. Thank you very much. Have a nice Sunday.
Thank you, Dr. Pragnesh, and my apologies once more for the technical hitch.
That's fine, sir.
Thank you, Dr. Pragnesh and Dr. Ganapathy, sir. Thank you. And viewers.
Thank you.
Bye all.